We are going, so just a few logistics. We are going to turn the chat off during this webinar, but you'll have access to the Q&A. What I'm going to do is share a lot of information first. We'll collect the Q&A as we go, and then we will answer as much of the Q&A as we can. John, do you mind turning off the chat for us? Perfect. Welcome everyone. I know a lot of us have Zoom fatigue at this point. I appreciate you joining for this, and I am excited to share with you what I can. My name is topic right. But the opinions and the suggestions represented today are my own, not those of the institutions that I work for, unless they're otherwise hyperlinked. I absolutely do not know everything. And there is a lot about COVID that we don't understand. And our understanding of this disease is rapidly evolving. And so what I tell you today is the best of my knowledge today, but it may be different based on what research comes out tomorrow. And so I really want to frame this as I'm going to do the best to share with you what I know and what I think will be helpful, with the caveat that we are learning more every day. In medical school, our professors often remind us that 50% of what they're teaching us is wrong. They just don't know which 50%. And so in many ways, I feel like that. What I am telling you today is the best of my knowledge. Some of it will surely be found to be wrong. We just don't know yet. So my objectives for today are threefold. My first goal is that on this call together, we develop a clear understanding to the extent scientifically able of how COVID is transmitted. Second, my goal is that you all become familiarized with the existing data about COVID transmission in children and understand its limitations. And we'll both explore some data that exists as well as some stories in the news that are currently emerging. Finally, and I think most importantly, is I want to help you all develop a harm reduction framework to think about how can you all keep yourselves, your staff, your students' families, how can we keep people as safe as possible during this era of COVID? I want to share that this presentation is not going to address whether or not in-person school should take place. That is a complex issue that I think relies on many factors and will be very different in different communities. And so I'm really going to focus on talking about transmission and existing data and helping folks develop a harm reduction framework rather than about whether or not school should happen. However, I hope that by the end of this presentation, you feel more informed towards whatever you're feeling about that question is. So to get us started, I want to root us in basics. So I know I am talking to a highly intelligent group of people who I would bet that 99.9% of you, if not 100%, are self-directed learners, which means that we have been hungry to try to learn everything we can about this disease and what it might mean for us and our families and our students. And there's a lot of information out there, and that information is very confusing, even for folks who are incredibly educated and good at researching, because this is a confusing disease. And so what I want to do is get us rooted in some of the basics. So as we understand it, COVID, which the virus is called SARS SARS-CoV-2, and the disease it causes is called COVID. In this talk, I'm going to use those interchangeably. So COVID, as we understand it, is primarily spread through droplets and likely spread through short-range aerosols, and I'll talk about what that means in just a second. But basically, if you were to put your hand in front of your mouth right now, while breathing, while talking, you'd feel a bit of moisture, and those are droplets. And when you cough or when you sneeze, those make either smaller droplets or short-range aerosols. And so in order to get COVID, infected droplets or infected short-range aerosols need to make contact with your mucous membranes, meaning it needs to have contact with your nose, the inner part of your nose, your mouth, or your eyes. A key concept that's going to come up later related to droplets is that droplets are heavy and they don't stay in the air indefinitely. They fall eventually to the ground but from the pull of gravity, and most droplets fall to the ground within an hour. So droplets are not free floating in the air. And I think that's really important as we think about transmission and minimizing transmission. So I'm going to go into much greater detail about these 4 key ideas later, but the big cornerstones for preventing something that is droplet transmitted involves covering the nose and the mouth, and the idea behind that is preventing droplets from getting in, maintaining 6 feet of distance, and I'll talk about like what is 3 feet versus 4 feet versus 6 feet versus 20 feet, because there's some really confusing messaging around that. But the idea here is keeping your droplets in enough of a radius of you that they're not spreading into another person's mucous membranes. Eye protection goes along with the idea of covering the nose and the mouth. And then hand washing is actually a really key tenet of COVID prevention. Most importantly, before touching mucous membranes. So we'll also talk more about the role of contact transmission, meaning touching things, but very big picture, very basic. These are the key ideas for preventing droplet transmission. The other thing I wanted to talk about before we really dive in is what a high-risk exposure is. So a high-risk exposure to COVID, and this is defined by the Center for Disease Control, is greater than 15 minutes within 6 feet of a person who's infected without the appropriate personal protective equipment, that being a mask and eye protection. So if I have COVID and you walk within a foot of me, and then you walk out of that bubble, that is not a high-risk exposure. But if you are talking to me from 4 feet away for 30 minutes and we're not wearing masks, that is a high-risk exposure. And so again, I want to sort of keep in mind this concept of what is a high-risk exposure as we think about different things that may happen within the school setting. So now what I'm going to pivot to is what we know about COVID and what we know about children. And as I'm doing this, I know that some people love digging into the data and some people are like, just tell me the bottom line. And so I have posted my slides and my hyperlink. If one of the panelists could share in the chat, but if you go to tinyurl.com/COVID and schools, you'll see my slides, and I've hyperlinked where all the data comes from if you'd like to look at it in more detail. Again, that's tinyurl.com/COVID and schools. Later tonight, I'll also post the recommendations I made for our district, and I'll post the recording when we have one at that website. So first, before I even get into the data, I want to talk about the limitations of this data. So we have only known about the existence of COVID for 7 months, which means we do not have anything truly longitudinal. The longest study that could even exist for this would be 7 months. We do not have years and years of data. Second, the data that we do have is not ideal. The ideal scientific study is a randomized control trial where you have one group doing one thing and another group trying another intervention and it's double blinded. And right now, that would not be ethical. So the data that we do have is from these small observational studies. These studies aren't randomized and they're not controlled. And so I think it's really important to have that understanding as we look at the data that we have at this point. Much of the data that we have related to children and transmission is from outside the United States. And so I want to go ahead and name that the data that we're looking at may not be and probably is not representative of the community that you work in. And so that also is going to affect the lens with which we look at the data. And then finally, and this ties to the prior point, is prevalence, meaning how much COVID is in the community, is likely a really important player in transmission in general. And so that's another thing for us to keep in mind as I start going into this data. And so what I'm going to do is share some data that we have from small observational studies, talk about the implications that come from them, and then share some of the stories that are coming up in the news, and then share what I think some of our big gaps are in terms of data that we're missing. So thinking about COVID, one thing that we've really seen from early on with this disease is that children are less likely to get COVID than adults. In terms of all the confirmed cases of COVID, only about 2% of those cases are in children. And children tend to get much less sick than adults from this disease. The rates of hospitalization in children are quite low. In the United States right now, it's a rate of 0.1 per 100,000, whereas adults are having about 70 times that rate. 7.4 per 100,000 is the rate of hospitalizations for adults ages 50 to 64. There have been very few deaths among children. And then MIS-C, which is the multi-system inflammatory syndrome, is quite rare. So in the United States, when I made this PowerPoint 3 or 4 days ago, there had been a total of 186 cases. So this is scary. We've had one case at the hospitals that I work at. However, it is getting a lot of press, but it's really quite a rare complication of COVID. I think we have a lot of participants on the call from California. So just to show some data from the California Department of Public Health, this is stratified by age. And this column here shows us the total number of cases of COVID in the age group. This is the percent of all COVID cases. And this is the percent in the population that group represents. So what you can see here is children under 5 so far have been 1.8% of the COVID cases in California, even though children are almost 6% of the population. So you can see, like, from this, there's a third less cases than you would, or two-thirds less cases than you would expect based on population amount. For the age group, and I realize for those of us in education, this is a huge range, right? Because it's elementary and middle and high school. But from 5 to 17-year-olds, they represent 6.4% of the COVID cases in California, but 16% of the population. And so what we're seeing is that rates of COVID are just not as high in children, in people under 18, than those over 18. So the first study I'm going to talk about is one that was done in Iceland. And so this is from early on in the pandemic. Iceland kept both their preschools and their elementary schools open and practiced social distancing. And what they found is that no children under the age of 10 out of close to 900 tested positive for COVID. And only 100 out of about 12,000 children, so that's 0.8% total, tested positive for COVID. And so what this suggests is that even when brought together, COVID transmission rates may still be very low in children relative to adults. But a note I put here is this, again, this is an observational study. This is in a place where social distancing was practiced and in a country that had very low prevalence of COVID. The next study I'm going to talk about is a study from Switzerland. And what these researchers did is they investigated 39 children who were hospitalized with COVID who were under age 16. And again, the vast majority of children with COVID are not getting hospitalized. So this is selecting a specific population within children who have COVID. And what they did was a lot of contact tracing. And what they found is that in 80% of the time, an adult in the household had symptoms either before the child did or concurrently. And interestingly, siblings in the same household were only half as likely as adults to develop symptoms. And so what this suggests is that adults may be more likely to pass SARS-CoV-2 to children than to receive COVID from their children. And it also seems that children were less likely to get COVID from each other than from adults. And so when we think about a school setting, this potentially has a lot of interesting implications. That said, this is a very small study, and it's an observational study. So another interesting observational study that I wanted to bring up is a case study that happened in France. And this is the story of a 9-year-old male who tested positive both for influenza and for coronavirus. And that student, before being aware of their positive status, had contact with more than 80 children in 3 different schools in France. And what was really interesting about this is 0 children contracted SARS-CoV-2, but 9 students who had what was considered a high-risk exposure contracted influenza virus. And so what this might suggest is that transmission of coronavirus, of SARS-CoV-2 in children, may be quite different than most childhood viruses, or at least in this case, in comparison to influenza virus. So why is this disease so different in young people? So I wanted to talk about one of the theories that has emerged around this, which is related to what's called the ACE2 receptor. So the ACE2 receptor, you can almost think of it as a lock, and it exists in our nasal mucosa, so inside our nose, and also in our lungs. And one of the things that they found with SARS-CoV-2 is that in order to enter the body, it needs to bind to an ACE2 receptor. So think almost like SARS-CoV-2 is a key going in the ACE2 receptor lock. And there have been some studies that show that children under 10 years old, that's this column right here, have much lower expression levels of the ACE2 receptor in their nose than children ages 10 to 17. That said, people who are 10 to 17 still have less ACE2 receptor expression than adults. And so this is a really interesting hypothesis that is a hypothesis to explain why might children be less affected and why might children seem to be less effective at transmitting. However, there's also some evidence against this hypothesis. So China reviewed about 2,000 pediatric cases in January and February. 90% of them were either asymptomatic, meaning no symptoms at all, had mild symptoms or moderate symptoms, but these were not severe cases. And what's interesting about this data is that the confirmed and suspected cases don't drastically differ by age group. So if we were expecting this data to coincide with the ACE2 receptor theory, we would expect many more cases in children over 15 and far fewer in younger children. And so this data doesn't fully support the ACE2 receptor hypothesis. This study down here is from Europe, and they looked at 582 cases in April from 25 European countries. And one thing I want to note, and that we can also talk about later, is that a quarter of these individuals had pre-existing medical conditions. In children, pre-existing medical conditions are diabetes, obesity, immunosuppression, congenital heart disease, and congenital anomalies. This is not usually asthma. And so what this shows is the age is on the y-axis, and then folks who are not admitted to an ICU, and then folks who are admitted to the intensive care setting. And if the ACE2 receptor hypothesis were true, we should actually see pretty large numbers. We should see like an inverse triangle shape. And what's really interesting is we do see fewer cases in elementary age students, but it really doesn't balloon up with the older ages. And what's interesting is that in the younger ages, so 2 and under, there were a lot more hospital and ICU cases. It is what one lens with which I've thought about this is those who are in the hospital are more likely to get tested for COVID because they're there and because we're testing them. And so I don't know to what degree that may play a role in this data. So I wanted to share a success story. So in both the YMCA, many of which have been open nationwide and have cared for more than 40,000 children, and in New York City, the Department of Education kept some sites open for children 1 to 14 who are the children of essential workers. And there were about 10,000 children and more than 170 sites. And despite caring for one of the highest risk pediatric populations in terms of being children of essential workers, they were very largely successful in terms of not having outbreaks. So a few staff did test positive, but they didn't have more than 1 positive case at any site. And we'll talk soon about harm reduction, but practices they had put into place were using pods, so set groups of students that didn't mix. Social distancing and mask use within pods was variable in the YMCA, but it was practiced in New York City. And then there was major attention to hand washing through both organizations. And so this is a success story from the epicenter of COVID in the United States, or the former epicenter, I should say. But there's a lot of stories in the news that are raising a lot of concern. So one of the earliest ones was 70 cases in France after school reopened. And these were cases that were found about a week into school happening. In total, 1.4 million students returned. I believe these areas were clustered in the northern region where rates of COVID were higher. One possibility for this is because they were detected a week in, it's actually possible that a lot of these cases were acquired before they went back to school and then became symptomatic or were prompted to test once they got there. I think what remains a question mark is how much transmission may have happened in that first week back. The second bullet here is about an outbreak in Israel. So the schools in Israel reopened in early May, and one school, which had both middle and high school, had as many as 130 positive cases. About 75% were in children and about 25% were in adults. And so stories like that definitely raise concern around transmission in schools. In the past week, there have been articles about 300 cases in daycares in Texas. And so I wrote down the data for you. So as of Tuesday, I think this was yesterday, Tuesday, there were 950 reported positive cases of COVID-19 in daycares. 307 were children and 643 were staff members. And these were at 668 different locations. In total, there are 12,207 licensed childcare operations are open. So what's interesting about this is that within daycares, there's actually twice as many staff members that have tested positive relative to children. And I don't think we have data about which direction those cases are coming from. But one thing I think to keep in mind is how what may be happening in Texas daycare may be different from what happens in New York City Department of Education, just in terms of what behaviors are practiced, not only in those spaces, but in the community, and how those may increase or decrease rates of transmission. So, you know, one question that the Texas situation raises is, you know, to what degree might this be connected to adult behavior versus to what degree may it be connected to children transmitting to adults? In Oregon, there was recently an article about how cases of COVID in children ages 10 and under grew 5-fold during the month of June, and was the most rapidly growing age range in which rates were growing. And what is interesting, and this article mentions it, is the thought is that most of this is largely due to unidentified transmission within the community, although outbreaks in daycare are also playing a small role. And so one of the things that this news highlights for me is not only how critical what's happening outside of school is to allowing for success with schooling, but also how important the idea of cohorting, having these small stable groups, will be to have containment when positive cases arise. Finally, there has also been news about pediatric cases jumping in Florida. I believe 1,200 new cases in children were detected over the weekend. Some of this may be due to increased testing capacity. Also, as I'm sure you all know, like Florida is surging right now, and there is more COVID in the community, there is higher prevalence, and so it makes sense that children are also getting infected more. What is encouraging is that pediatric hospitalizations in Florida have not risen. There's a lot of unknowns. I listed a few of them here. There's many more than these, but there's a lot of unknowns. One thing that I think we still don't have a clear answer on at all is how effective is asymptomatic transmission? For someone who has COVID and no symptoms, how good are they at infecting other people, both kids and adults? How effective, whether symptomatic or not, are children at infecting adults? And I think we have some scant data on this, but this is really an area that needs more explanation. Another question is, you know, as I mentioned, we've had this disease for 7 months. That's it. And so for children who have mild cases of COVID, because the vast majority, 90% of pediatric cases are quite mild, are there long-term sequelae? I just don't think we know yet. Another question that I've yet to see data on is, what size should a cohort be? And I'll talk more about this, but as far as I can tell, this isn't something that's been extensively studied. So key takeaways from this research portion is the data is very limited. More is coming out every day, but the data that we have is limited. There is some encouraging data related to youth and transmission, and there's also recent news reports that are concerning. We undoubtedly need more data, particularly for preschool and for middle school. And so in some of the data I think you've seen, it's divided as children below 10 and children ages 10 to 17. And that carries a big range, right? That's like 5th grade through 12th grade. And so one thing I think that's really important going forward is to try to understand our middle schoolers having transmission patterns and effects similar to high school, or are there patterns more similar to elementary school? Context matters. What the prevalence is in the area matters. Behavior matters. And then one thing that I think is really crucial for us to remember is that adults, based on the data we have up to this point, an adult is at most risk of transmission from another adult, based on what we have so far, as compared to transmission from an infected child. So I'm going to take a sip of water. I'll let you digest that. And then I'm going to sort of switch to the practical aspects of this. All right, so let's get practical. how, how might we think about school in the era of COVID? So I think the best analogy for this is the way we think about safe sex. There are things that we can do that can 100% reduce your risk, and that may or may not be feasible for everyone. And so there are a lot of other steps that can be taken to mitigate risk. Transmission is not going to be zero. Every one of us wants it to be zero. And the reality is that it's not going to be zero. But there's many steps that can be taken to reduce the risk of transmission. And as I go through these steps that we can take, some of them you're gonna be like, that's not gonna work. I can't do that in my classroom. I can't do that for my kids. And I get it. My goal is to give you a menu of things and for you to think about what's practical and feasible that you can implement. And there might be sort of a best, and if you can't do the best, like, okay, what might you do? What other steps can you put into place to minimize risk? So here we go. I'm going to talk about 7 key concepts. So I'm going to talk about personal protective equipment, what makes sense for kids, what makes sense for staff. I'm going to talk about physical distancing and how to think about it. I'm going to talk a little bit about hand washing and this idea of deep cleans. Oh no, that's number 5. I'm going to talk about symptom screening and temperature checks and their roles and their limitations. I'm going to talk about ventilation, and I'm going to talk about testing and contact tracing. After that, I'm going to talk about certain scenarios like lunch or physical education or itinerant workers. Here we go. So personal protective equipment, from now on, I'm going to say PPE. And I've spent a lot of time thinking about this and a lot of time speaking to people on the medical side and also who have different roles in the school. And so I think for general education staff, what makes sense is a mask covering the mouth and the nose, and a face shield encouraged. So the idea behind the mask is that it is keeping that person's droplets contained, and it's also providing a layer of protection of droplets getting into them. I have not seen a study yet that compares cloth masks and surgical masks. I think either could serve this purpose, and a lot of it may come down to functionality and preference. I think a face shield should be encouraged. The idea behind a face shield is that it protects the eyes and it gives an added layer of protection to the mouth and the nose. This has less to do, I mean, it is an extra layer for containing a person's droplets, but it's more designed to be additional protection for the person wearing it. And so that's why I think it can be encouraged, but doesn't necessarily need to be mandatory. Similarly, I think for students, it is helpful to have a mask covering the nose and the mouth, and a face shield is something that is optional and could be very helpful. I've gotten a lot of questions about, can they do face shields in place of a mask? And so a face shield is not equivalent to a mask because the sides and the bottom are open. I think it's better than nothing at all, but I don't think it's a one-to-one replacement for a mask. There are some populations at school who I think may benefit from more extensive personalized protective equipment. So I'm going to talk about N95s in a minute, but people who definitely need more personal protective equipment are nursing and anyone who's giving a nebulizer or suctioning someone or working with someone who has a trach tube in their neck. For those 2 groups, in times when they are within 6 feet of the people that they are working with, especially if they're working with students who can't control their secretions or they're doing aerosolizing procedures, it may make sense to have an N95 mask, and I'll go over what this is and how it works in a minute, with a surgical mask covering it. And the idea is just that allows you to reuse a surgical mask, a face shield, a gown, and gloves. For janitorial staff, if they are using aerosolizing sprays, hopefully they're not, but if they are, an N95 would make sense for them as well. And I think if they're cleaning surfaces, it's reasonable for them to also have access to gown and gloves. For individuals who work with students in SDC classes who are moderate to severe, who may not be able to tolerate a mask, who may not be able to manage their secretions, who may not be able to verbalize if they're symptomatic, or who may need to be in close proximity for long periods of time. This is a group for whom, in addition to a regular mask and face shield, I think there should be some consideration to offering gown and gloves as well, since they're more likely to have droplets land on them than a staff member who is over 6 feet away. So a word on masks. So the bottom right is a cloth mask. This is great. Go for it. Make sure it covers the mouth and nose. Surgical mask, same thing. This is great. Make sure it covers the mouth and the nose. An N95 mask has a different purpose. So the purpose of an N95 mask is to keep out aerosols. And so that's why it's recommended for aerosol generating procedures. An N95 should be specially fitted. These are very tight fit. They feel quite suffocating to be in. And they are, the reason that emergency room staff wears these is when they're doing intubations or swabbing or aerosolizing procedures. When I see a patient for a headache or a laceration or something like that, even though I'm within 6 feet of them, I wear a surgical mask and I wear a face shield. One thing I really want folks to understand is that this kind of N95 is dangerous. This is a one-way valve. And so these were designed, I think maybe for painting. And the idea was that you would keep everything in the world out, but by breathing, by exhaling out, and essentially having a jet stream out, you are getting, you cool off. But this is very dangerous when an N95 is related to infection, because this essentially puts out a jet stream of air. And so if a person is infected, it's putting out a stream of infected breath. All right, this is a face shield. It is basically a piece of plastic that covers the face, covers the eyes, and covers the mask. And what you can see is that the sides are open, and this is why it's not the equivalent to a face mask. Okay, what is the deal with physical distancing? I have heard 3 feet, I have heard 6 feet. My district said 6 feet, and now they say 4 feet. What, 20 feet? Like, what is this? So a study in the 1940s looked at how most droplets fall. And for the vast majority of people, the majority of droplets fall within 3 feet. And so we decided to be conservative and doubled that number to 6 feet. And that is where 6 feet comes from. And so when we are speaking at a normal volume, the majority of our droplets fall within 3 feet of us. Some may go 6 feet of us. If we are coughing or sneezing, those droplets go a lot further. If we are singing or yelling, those droplets can go a lot further. When I say a lot further, I'm talking 20 feet further. And so when we think about spacing of children, certainly 3 feet is important. When we're thinking about 3 feet versus 6 feet, it becomes an issue of risk benefit, right? Is it the difference between being able to get a lot more young people in your classroom, and do the benefits outweigh the trade-offs? And so I just give you that information to think about. And then if chorus is happening, or if it's PE, I would strongly advise having students much further than 6 feet apart, because when they're breathing heavily, their droplets are going a lot further. So I share this with you to give you a sense of how to think about distancing, and to recognize that, to understand where 6 feet comes from, and to think about it in the different contexts that may exist in your school setting. Okay. I know that you know that hand washing is critical. I don't know what your environment is like, but I know that in the bathroom next to my classroom, I can find soap about 40% of the time. Hand washing is really critical. And so one of the most important things for us as sites is going to be to have ample soap and hand sanitizer available. Either hand sanitizer or soap and water can be used in most cases. The exception is if the hands are visibly soiled, and if that's the case, soap and water needs to be used. Just a reminder that nails harbor a lot of germs, and so teaching kids to be able to get under their nails is going to be important. The idea here is to wash hands before touching the nose or the mouth or the eyes. That is the whole goal, right? Is if there is virus on your fingers, that you get it off before you're putting your fingers in any of your mucous membranes. And so there's been a lot of enthusiasm around this concept of deep cleans and wiping down surfaces all the time. And that is really challenging to do. And the more important thing, yes, I will talk about cleaning surfaces, but the most important thing is that if hands have been on those surfaces, that they're getting cleaned before they're going in the mucous membranes. So speaking of cleaning, so where does it make sense to wipe down surfaces more frequently? It makes sense for high touch surfaces and for shared objects. So things that are being touched a lot, it makes sense to wipe them down more often than we did in the pre-COVID area. If you cannot wipe them all the time, it's most important that you wipe them down, or that they are wiped down between different cohorts of students. There is a lot of anxiety around the bathroom. And in terms of COVID, the bathroom is not an especially scary place, as long as hands are getting washed before touching the mouth and the nose or the eyes. So if we think about a doorknob, maybe 20 kids have touched the doorknob, and that's okay as long as after they touch it, they're gelling before they touch their face. Also, the more that we can eliminate the high touch surfaces, so for example, instead of having a doorknob that's being turned all the time, if we can open the door and hold it open for kids, that helps reduce the need for the surface needing to be frequently cleaned. So those are my thoughts on cleaning. Small stable cohorts. What I mean by this is small groups of students that are stable. And the idea behind this is that it limits the number of students that they're exposed to, and it makes it easy to understand who needs to quarantine in the event of a positive. Cohorts are also helpful when there are limited resources to think about how cleaning might happen. So for example, maybe a cohort is at school Monday, Tuesday, and then a thorough clean happens Wednesday before a Thursday, Friday cohort comes in. There is no magic number that I've been able to find of what makes a cohort. So I often see 12, but I actually wonder if that's more from the educational end, that we can do pairs, 2 groups of 6, 3 groups of 4, 4 groups of 3, but I haven't found anything medical behind the number of 12. And so what I would encourage you to do is use the space that you have as a guide for this. And then again, if you are doing deeper cleaning, it makes sense to do that particularly between cohorts. With ventilation, the idea is that ventilation scatters droplets so that a smaller concentration is inhaled. The less you inhale, the less your chance of getting sick. And so as much as the outdoors can be utilized, the better. I recognize this is much more feasible for the folks in San Jose, California than the folks in Portland, Maine. Opening windows when possible is another way to help ventilation. All right, symptom screening. So the bottom line is, if people have symptoms, they should stay home. If people have had exposure, a high-risk exposure to someone with COVID, or has a family member sick at home, they should stay home. Now it's going to get tricky. In adults, COVID symptoms are often fever, loss of taste and smell, myalgias, which means body aches, and cough. In kids, there's often a very different presentation of COVID. Only about half of kids who have tested positive for COVID have had fevers. Often they have stomach symptoms like nausea or vomiting or diarrhea. Sometimes they might present with just a headache. And many children with COVID are entirely asymptomatic, or their symptoms are so mild they might not have been caught. So this brings me to the concept of temperature checks. So I don't think that temperature checks are especially helpful, because half of children, at least with COVID, don't have fevers. To do temperature checks requires a huge amount of resource utilization. It gets very tricky between HIPAA, which is medical privacy, and FERPA, which is educational privacy. doing them could create a sense of false reassurance. If half of kids who have COVID wouldn't screen positive with this anyway, we feel better that we're doing temperature checks, but this may not be actually catching the cases of COVID in our communities. In terms of when might it be helpful, I think that the situation in which temperature checks might be most helpful are in children who are not verbal and might not be able to express that they're feeling nauseous or to express that they're having a headache. And also in children who may not be able to wear a mask. I think these populations overlap. Staying at home if symptomatic is really important. In terms of thinking about public health and reducing outbreaks and transmission. And one of the things that I think is super important for schools and districts to think about is creating policies that do not penalize children or staff for staying home when sick. And we need to be careful that we're not incentivizing to come to school when they're symptomatic, because that is how we're going to end up with outbreaks. There's definitely a role for testing and contact tracing. The idea behind this is to minimize outbreaks. So I want to remind us that people don't always test positive right away. It can take time to develop what would appear positive on a test. Certainly if someone's symptomatic or has a known exposure, they should get tested, and it's important that staff and students have access to a prompt test. Also, there needs to be a plan for contact tracing, and this could be within the district. It also could be in conjunction with local departments of health, depending on where resources are at. That'll be important for notification and quarantine. There has been some push for routine surveillance. I think in many ways this is a little bit like a temperature check in that it's very costly and may have somewhat limited efficacy in that there is a false negative rate. Don't want to quote it, but there is a false negative rate, which means there will be false negatives. And also not everybody tests positive right away. So then there also could be a sense of false reassurance. So absolutely testing and contact tracing is important, especially access for those who are symptomatic or who have a known exposure is going to be really important. So basic reminders: wear appropriate PPE, physically distance when you can, wash hands before touching face, and remember that staff-to-staff transmission is likely the highest risk and it's going to require the most intensive precautions. So I am available till 4:30, but I realize many of you may need to go at 4. I'm going to whip through these other things real quick within the next 3 minutes, and then I'll move to questions, and I'm available for 40 minutes to do Q&A. Lunch outside and spaced out is most ideal, especially because masks are going to be down. If that's not feasible, in the classroom at least 6 feet apart would be great. If the food can be delivered to the classroom so that children are moving around less, that's helpful. If that's not feasible, if the cafeteria needs to be sanitize them on the way in, which is before they're touching their mouths, and on the way out is going to be important, staggering times to the degree possible, and then keeping kids cohorted or even assigning seats in the cafeteria so that students are in proximity to the same people on a daily basis. In the event that there is a positive and contact tracing needs to happen, it will make someone's life so much easier if kids have a set location. For phys ed, outside when possible. If it's outside and you're able to space kids 15 to 20 feet apart, they don't necessarily need to be masked. If it's inside, masks would be a great idea. Trying to keep stable cohorts and minimizing contact with the floor. If students can bring their own water bottles, that eliminates the need for another shared space that is what we would call a fomite, or a good space for sharing germs. If there are locker rooms, if those can be avoided, that's helpful. Transportation is really tricky. If schools are doing symptom screens, I would highly recommend finding a way to do them before the child gets on the bus. And it not only exposes everybody on the bus, but then also the school needs to figure out how to get that child back home. Assigned seats when possible would be helpful. Same idea as the cafeteria. Stable cohorts. This is a place where wearing masks would really be helpful since students are likely going to be closer than 6 feet together. Minimizing other adults, and then sanitizing between cohorts. Itinerant workers, I know I saw at least one speech language pathologist policies can be either clustered, so instead of 1 hour 3 times a week, 3 hours once a week, or hybrid, online and in person. Ideally, you would want to have materials for each student. I know that's not always feasible, so if not, at least wiping down materials between students, avoiding porous things or things that fit under the fingernails. If possible, at least try to have the same materials for the same school. And then there's a real opportunity here for practicing hand washing together before and after the session. A couple thoughts about vaccines and herd immunity. I strongly believe that we cannot rely on this. I'm a pediatrician, we love vaccines, and I really don't think we can rely on this. Vaccines take a long time to make. Even if we do make a vaccine, we don't know how long immunity would be conferred for. Given the pathophysiology of this disease, given that a lot of the morbidity comes from an inflammatory or an immunologic reaction, I suspect it will be very would vaccine as a technology even work for this? There's a lot of anti-vaccine sentiment already. A lot of people who've had COVID are not developing antibodies. Even when they do have antibodies, we don't know if they're protective. There are some cases in South Korea of reinfection that raise a lot of concern about that. And even if they are protective, we don't know how long they'll work for. So, sorry to pass along a very sobering message, but I think there's this, I think many of us have this hope for like it's all right, like a vaccine will come, there will be herd immunity, but I think we really have to think about how can we do things most safely in the event that it takes a very long time to get to this vaccine or to herd immunity. Here are my key concepts. I'm not going to go back over those. And then I've linked some resources and guidelines. So the American Academy of Pediatrics put out some considerations. They're broad, they're vague. I think that's to allow customization between different communities and different needs. The CDC has also put forth some things, and then your state and your county departments of public health likely have a lot of advice. And advice differs between places because we are still learning and a lot of things aren't clear. And so it's super frustrating to not have an absolute guide for how to do things. And the reason for that is we are figuring it out and we are learning more each day. So I am going to pause. I'm going to let Jack Ju feed me some questions for Q&A. Again, I will post this webinar. The slides are already posted at tinyurl.com/COVID-and-schools.
Hi, Dr. Frank. So our first question is about how frequently should staff and students reuse or discard their masks or wash their masks?
Oh, that's a great question. I think for kids, having multiple masks, having like 3 to 4 masks would be helpful so that each day they're alternating. And so maybe you wear a mask Monday and it'd be great if you can wear a different mask Tuesday, and maybe you put the Monday mask in the wash at that time. In terms of evidence on that, I don't know. That would be my logical thinking about it, but I do not have data to back up that answer.
Our next question comes from a teacher who asks that teachers often have community supplies. However, if you're in a school that can't afford to pay for individual sets and families can't afford to pay for individual sets, or the school itself doesn't have enough room to store that, how do we think about supplies in our classrooms?
Great question. So in terms, and that's like such a real scenario for so many of us, and this is something that's been on my mind a lot for my classroom. And so I think that trying to limit use between cohorts. So if you are teaching 2 different groups of students in a day, I would try to use with just one group of students that day and then clean it and then use it with the other group the next day. And so to really sort of allow time and cleaning to happen between different groups of students using them. In terms of like within a single day, right? Like if a ball or something is getting passed around the room, again, if you can modify your practice to not do that, it's helpful. If you do need to do that, then you have to sort of think about risk benefit. And if you have the same 12 kids, if you're in elementary or pre-K, TK, those 12 students are exposed to each other's germs. And so if they're touching the ball that their classmate touched and it's been accepted that that risk is happening, then the most helpful thing to do is to keep that risk within that cohort of students.
Our next question is related to cohorts as well. For PE, you suggested 1 hour between cohorts when they enter an indoor space. But what is the for a classroom? If there's an AM group and a PM group, how much time should be between those two?
Yeah, so again, sort of using logic to think about this, most droplets are going to fall to the ground in an hour. And so if you can do on-site cleaning between cohorts, it makes sense to, I think there's two options. One is to clean the room right after the first cohort leaves with either the teacher, the custodial staff, and protective equipment, and then give an hour for the droplets that may have been kicked up from cleaning to settle. If there's an adequate PPE available or something of that sort, maybe you give it an hour for whatever droplets are there to settle, you clean, and then you give another hour for things to settle after cleaning. In terms of thinking about feasibility, I would recommend putting on, appropriate protective wear, cleaning, giving things an hour to settle, and then going back in.
We have several questions about the presence of COVID in the community of our schools. In one case, a person shared that 10.8% of cases in their county are in ages 19 or under, and the data isn't broken down any further. At what point does that rate of COVID in children become concerning to you as a doctor?
I think that's an epidemiological question. I think it's a really good point, and I think that's really, like, thinking about the local prevalence in kids is really important when thinking about whether or not school is safe. I don't know what threshold is and isn't okay. That's something that I would be interested in reaching out to the epidemiologists and to the Department of Public Health to better understand that. It's a really good, really important question that's weighing heavily on my mind. My school that I teach at is in the zip code of the county with the highest rates. And I don't know at what number it is and isn't okay. And I think that's an incredibly important question for our public health experts.
Thank you. Our next question is about, we're getting a few, some about HVAC scrubbers and others about air conditioning units as potential ways to disperse the virus in the air. Do you have any thoughts on those devices?
I don't know a ton about, I definitely can't comment on air conditioners. I think HVACs can be helpful. I think feasibility raises another question. But certainly, HVACs are filters that can help filter things. I don't know if air conditioning would more likely blow things around in a helpful way or in a not helpful way. I just don't know the answer to that. I think that when I think about a hierarchy of what I myself am comfortable in, I am comfortable in teaching in a closed classroom with no windows if I have the protective equipment that I need, but I would not be comfortable teaching in a room with an HVAC and no protective equipment. So for me, that's kind of personally how I feel in terms of comfort and priority. And I don't know the HVAC data or air conditioning data well enough to be able to give high quality advice. I'm sorry.
Our next question is about restrooms. How critical is it to have hot water in restrooms for students and staff, or is it okay to have just cold water?
I think cold water is fine as long as there's soap and 20 seconds of scrubbing. It doesn't feel as nice, but I think in terms of getting germs off the hands, it's fine.
Another practical question. One person asks about face shields with cloth draped down over the neck. How effective are those?
It is better than a face shield alone and still not equivalent to a mask because the sides are open. So I think to be as equivalent as a mask, it would like sort of involve a whole hood. I don't know if those are being made. If anyone's entrepreneurial, I think it'd be a great idea because I know how important it is in both speech and language and the younger grades that children are able to see the movement of the lips. So I think about that as harm reduction. It's better than only a face shield, but probably not quite equivalent to mask with face shield.
Thoughts on folks in our community, teachers and students alike, who are among high-risk groups, and how you think about folks in high-risk groups?
Yeah, it's a challenging question. Also because I take care of children and not adults. I think anybody who is high risk should be having a conversation with their doctor, who knows really well, like their health history, the medications they may or may not be on, the amount of immunosuppression they may or may not have. I think it's really important to have individual conversations with doctors to sort of think through risk. Certainly for high-risk people that are working in the classroom or working or students in the classroom, the precautions become even more important. So using PPE all the time, extra hand washing, being really cognizant about distancing is especially important. It's important for all of us, but it's especially important for the folks that are high risk. Whether or not it's safe for them to physically be in the classroom, I think is really individual and involves a conversation with a medical professional who knows your medical history.
Our next question is kind of a pedagogical one, but it's from a teacher who asks about small group discussions versus whole group discussions in the classroom, and what your recommendations are for how students should be engaging with each other in the classroom space.
That is a great question. I think that, and I imagine this depends on the age of the students you're working with as well. But again, small stable cohorts are helpful. And so if you have students in 4s or 6s and you want them to have discussion, it's really helpful if they can have that same group for a prolonged period of time so that they're having the same exposures. The other thing I think about is that when you are talking to someone who is less far away from you than someone who's across the room, you're less likely to shout and send your droplets further. So I think either can be made to work as long as deliberate thought is put into it. But I think in terms of reducing transmission risk, having smaller group conversations with the same students may be helpful, both for keeping droplets contained and keeping like closer contacts contained.
That's helpful to me just as a teacher as well. Our next question is about younger grades in elementary school, and it's about effective monitoring. So do you have any suggestions or have heard of any success stories about how to effectively monitor proper hand washing and mask wearing? Another related question is, do you have any recommendations for picking a good mask for young kids?
Great questions. I can get back to folks with good mask recommendations, but the bottom line is one that fits. And by fits, I mean it covers the nose and the mouth, it doesn't fall down all the time, and it's not massively gaping at the sides. Can you remind me of the other part of the question?
Yeah, monitoring proper hand washing.
Oh, what is amazing about those of you who are lower elementary teachers is you are phenomenal at teaching procedures. And I would think about this a lot like a classroom procedure, where not only are you teaching really explicitly the different steps of it, but like you're recognizing where it happens well, and you're also teaching children ways to like positively monitor each other or like help a friend keep them as safe as possible. And I think for masks as well. I made just like an introductory curriculum that I can also put on the tiny URL that sort of has the basics. And there are things like showing pictures of people with masks on improperly. And so trying to recognize what is not the right way to wear a mask, and how might we kindly help each other wear masks correctly. So I think a lot of explicit teaching is important around this. And just as you would teach students like how to line up to go to the gym, like this takes the same, if not even more, like detail and attention to really teaching it and really like elevating the behaviors as possible. And then I guess my other thought would be, if there are students who have shown like they are really excellent hand washers, can they become hand washer monitors to be an extra set of eyes for you?
Thank you for the suggestions. Another question from a teacher: if you were going back to school, what do you envision would be the most helpful for your parents and for community members? So in other words, how can parents and other folks in your community help you the most, with supplies or with financial support, with cleaning time?
That is such a kind question. Thank you to whoever asked that question. I think that the most important thing for school to work is going to be safe community practices. And so really promoting these precautions, not just in school, but outside of school, and then keeping people home if they're symptomatic, is some of the most important help that the community can provide. I think the next step would be, I imagine it varies school to school as to what might be most helpful. Like for some sites or some teachers, it might be helping wipe down equipment. For others, it might be helping monitor that kids are far apart at lunch. I think that may be a school to school issue, to be honest. As you can tell from my response, I haven't thought about that question. It's a beautiful question. And I really appreciate it. And I would encourage you to reach out to your school or your child's teacher with that question.
This question is about cohorts. If the goal is to keep cohorts small for the same children, can those students do after school activities or do socially distanced play dates with children outside of that cohort?
So this is where it becomes harm reduction again. And risk benefit and what are people comfortable with. So certainly it's easiest if the same kids are cohorted outside us in after school, ideally on the bus, in whom they play with, right? That's the ideal. Is that feasible? I have lots of question marks floating around. And so how can harm reduction happen? So maybe it's just combination of kids from two cohorts. Or, one of the things that's really helpful is, if 12 kids are cohorted in a class and they want to play with someone else, maybe those are the times that families are extra careful about actually enforcing 6 feet or, really carefully wearing a mask. So I don't have an absolute on that. What I'll point out is that the more mixing there is, the more exposure and the harder contact tracing and outbreak reduction is going to be. But I don't think it's an okay, not okay question. I think it's what level of risk is the community comfortable with, and what are the trade-offs between challenge of keeping kids fully cohorted and risk of more exposure.
This is more of an admin logistical question, but if a teacher is sick one day, they call in a sick day, but it's not necessarily COVID, do you think it is more worth it to have the kids stay home too?
Oh, I'm going to take that via allergies. I need to stay home. And unfortunately, I probably need to get COVID tested in days with no symptoms. And that's with no COVID. If I have COVID, I'm going to be out for a lot longer, at least 10 days. And there's varying guidelines between 10 days and 14 days. And until I've been 3 days without symptoms. So very few absences, I think, are going to be one-day absences. The exception to that is if I break my arm, that is 100% not COVID related, then that's a 1-day absence. And so I think it then depends on your substitute pool. If I know in my district, it is extraordinarily hard to find substitutes. And so it may be helpful to have children stay home. But if you're in a system where you can actually get a substitute who's familiar, like that, that's familiar with your school's rules, that can pick up a job for 5 to 10 days, then I think that's a good way to go. I think it depends on a lot of logistical factors within your school setting and school community. But the key point from that is that most people out with a symptom are going to be out for at least a couple days.
And what do you recommend for service providers like speech therapists or physical therapists who generally see students across maybe one or more schools or one or more cohorts? What do you recommend for those folks?
To the degree that you're able to cohort, and I highly recommend talking to your supervisor, your district level supervisor, to really think about how can you cohort the sites that you're at and maximize the time that you're at a single site. So if normally you're at school A Monday, Wednesday, Friday, and you're at B Tuesday, Thursday, can you cluster your visits to site A together? Can you cluster your visits to site B together? In some cases, I know that's not going to be possible. And so for when it's not, how much can you consolidate? How much can you cohort? Can you have a separate set of supplies that you use for that school site? If not, can you build in adequate time for yourself to clean those supplies before you go to your next school site? And then in your case, just being extra attentive to hand washing, I would wipe down your face shield between sites and possibly change your mask between sites as well. And that way, if there's found to be an outbreak at one site that you work at, the goal is for you to not bring that directly into every other site that you work at. So these precautions become extra important for you, not only for yourself, but for you as a vehicle of potentially disease coming from another place.
This next question is also related to kind of multiple schools. This person works at a school in a community center with other schools in partnerships. And so the public bathrooms there are kind of less than ideal. What do you recommend as the process for students and staff to kind of approach these bathrooms? And then the person also asks about a bathroom caddy or offering supplies for students. Is this a good idea?
I think that the best way to mitigate that is to actually have a hand washing station outside the bathroom. And to really train students, do not touch your face until you have come back to this hand washing station. I think, if they touch a door that someone else has touched, if they touch the handle that someone else has touched, like I don't know that if kids are on hand sanitizer to sanitize their hands, I can see that being very helpful. But I think the best way to mitigate is have hand washing after they've touched all the common touch surfaces, and really emphasize this point of when you go to the bathroom, you cannot touch your face until you've washed your hands. And all especially I work with teenage girls, right? Like all the desire to like fix the makeup and all of that, like not until your hands are washed.
This next question is a difficult one with many answers, but how do you go about and how do you recommend helping manage the stress of children during COVID and during school?
Great question. And there's so many levels of stress from this. I think that knowledge is power. And so I think helping students understand like what is COVID and how does it work and how doesn't it work, the same way that often in our curriculum we're very explicit about teaching what is HIV and how does it work. I think COVID takes that kind of attention, if not more. And then I think finding ways to empower students is really important, right? The things that we don't have control over are the scariest things. And so what sorts of things can we help students have control over? We can teach them how to be really excellent hand washers. We can teach them how to wear your mask in the safest way possible. We can, the things that we can teach them can be helpful. And then another thing that I think helped my ninth graders a lot was we started doing a lot of COVID-related advocacy. And so not only did they learn about it and the unknown became known, but they also felt that they were doing something active to help the community and help reduce rates. And having that kind of empowerment and the feeling that you can do something about it, I think is really powerful in the face of feeling helpless. On a broader level, this has been traumatic for all of us, for students, for teachers, for our loved ones. And I think there's a lot of trauma that's going to be associated with returning as well. And so I think at the school site level, really thinking about what steps can be taken to support socio-emotional learning and coping with trauma, and thinking about how do we manage our own self-care as educators and as a staff, but also that our students and our students' families are experiencing, is critical for being able to return, and honestly critical in the distance setting as well, even though it can be a lot harder to achieve.
To you.
That is not a great answer for the climate. If dryers are being used, if they can be no touch dryers, that's better than a touch dryer, right? It's removing a surface. But one of the problems with hand dryers is like they kind of blow around the stuff that's on the hands. And so that's why paper towels are preferable. And so in terms of thinking about school investments, soap and hand sanitizer and paper towels is something that I would really strongly advocate for.
I know you touched on this already, but we have several specialist teachers writing in, folks like librarians or school psychologists, asking, is it safe to visit the classrooms of a school, a grade level, or the entire school, as many of these folks work with students across the school?
Oh, that's a great question. And I actually have a different answer, I think, for librarians than, for example, a school psychologist or an SLP. So for folks who are itinerant workers, if you can have the child come to you, that is really helpful. Because especially if you're going between different school sites, if you can stay in one or two places within a school, also if you can do your work outside, that's really helpful in terms of reducing transmission risk. But that's really helpful. I know sometimes staff will push into classrooms, and I think in the COVID era, that is like higher risk because you are exposed to a lot of different children at different sites and different cohorts. And so the more that a child can be called by the main office to come to you, that may really help in the event of a positive, that may really help overall transmission risk. In terms of the library, so if the librarian is between a single site or between two school sites, I think for the librarian to actually go to the classrooms and then just practice, wearing PPE and distancing, I think that can probably work fine. Why do I draw such a distinction between librarians versus itinerant staff? So itinerant staff are also more likely to be working closer to a student. So if you're doing physical therapy, you're probably touching a student. If you're doing speech language pathology, kids are working on their enunciation and maybe spitting. Whereas hopefully if you're a librarian, hopefully most of the time you're able to maintain distancing. And so that's why I think it's lower risk for you to go classroom to classroom than someone who's an SLP or a PT or an OT. These are hard questions. I appreciate them.
A related one, just as another school psychologist question, what about observing students in classrooms? Do you also discourage that or finding other ways to observe?
If you need to observe in the classroom, is there somewhere that you can go that's like 10 feet away? And if so, and if you're in PPE, I think that's okay. But I think, you know, needing to be next to a kid in a bunch of classrooms, then you run into that issue again where you're just having close exposure to a lot of kids, which raises risk for them and for you. But I think from a distance, that can certainly be done.
Thank you. What are your thoughts on gloves as PPE in a school setting?
Not helpful, with the exception of when cleaning is happening. So gloves, the idea behind gloves in general is to, for example, in the hospital, if I'm going to sew up a laceration, I wear gloves so that I don't get blood on my fingers. And then I take the blood off I take the gloves off and wash my hands before I touch anything else. And so if gloves are being used in that way, that's fine. But often what happens with gloves, and I see this in the grocery store all the time, is people have the gloves on and then they're like touching their face and they're touching other things, and then it completely defeats the purpose of gloves. The other thing is that that in the beginning of this disease, we thought that contact transmission, meaning touching things, played a really large role. And over time, it's become clear that that's playing much less of a role than droplet transmission. So, you know, if a kid just spit all over their desk and you're cleaning it, by all means, put on gloves, clean their desk, and take them off. But I think regularly wearing gloves is no more helpful than washing your hands before you touch your face.
Our next question is about handling unsafe situations at school in which multiple adults need to be in close contact with one or more students. What are your thoughts on those kinds of situations?
Yeah, those will inevitably come up. I think that it's important for schools, like the main office, to have, wherever they have their like defibrillator and their first aid kit, to also have some PPE of situations. And so if, you know, a number of adults who's kicking or screaming or having a medical situation or needing to give CPR, that's when you run and grab the box, send someone to grab the box, put on your PPE, and support that way.
Our next question is about food and sharing it. Students often share food with each other, or teachers want to hold parties for their students. Is that unsafe at this point?
Yeah. The way that things could be shared safely is different packages. So if it's a birthday and that really wants to be celebrated, bring a box full of granola bars or something that's individually wrapped to share. Pulling from the same container is not a great idea. And then especially like if a student bites off a granola bar and hands it to their friends, that's putting their saliva straight into a mucous membrane. So except for individually wrapped packages, unfortunately, like food sharing in the COVID era is not a good idea. And it's an even worse idea for staff. And it kills me to say that because I love all the sweets that show up in our staff room. And it is not a great time for that.
We just have a few more minutes, but another question is about the use of classroom resources. So paper handouts or poster boards or even a classroom library. Does the virus really stick to paper surfaces?
Great question. We know that the virus can live on, the virus can exist on surfaces for a long time. Some studies that I've seen have shown as much as 17 days. What we don't know is if it's still infective. So that's an area where we really need more data to better understand what is and isn't safe.
One teacher asks that they have a student who has refused to wash their hands because he was told by his parents that COVID is made up. And so what do we do? What do you recommend about students and parents and members of our community who refuse to wash their hands or have kind of misconceptions about COVID-19?
Yeah, that is challenging for sure, and it is inevitable. I think this is one of those spaces where I think that we have to make sure that staff is protected and safe, because staff are at higher risk of getting sick, of getting seriously sick, of getting hospitalized, and such. And so the most important thing in those situations is that staff has adequate access to personal protective equipment. All right, so what about the kid? So, if the child is not washing their hands, then they are assuming higher risk for getting COVID. And then the next question is, to what degree do we protect the rest of the students in that classroom who are washing their hands and who are wearing their masks? And so I think one option, and this is from an infection, this is my infection hat rather than my teacher hat for this moment. One thought is to put the children who will not wear masks, who will not wash their hands, in the same educational space with a educator who has complete PPE, and then those students are with other students who are at higher risk, and the educator is still being protected. I am sure if I switch my educator hat on, there's a lot of questions related to the inequity of doing that. And then I think it becomes like a conversation of the school site and also the families in the school of, are they willing to have that, right? If their child is wearing a mask, and that mask largely protects that child, but what level of risk is the community, the families that are sending their kids to school, comfortable assuming? And I think ultimately that, as shared decision making, both with families and with staff, is important to figuring out those policies. So from an infection control standpoint, you put the high risk folks together, but from an educational perspective, it's a lot more complicated than that. I think we have time for maybe one last question.
Sure. These are tough dilemmas. What are your thoughts on, let me rephrase that. What should staff who have high-risk conditions or who live with people who have high-risk conditions do when they come home from work?
Ooh, great question. I frequently work in the emergency room, and so I think a lot about this question. So I would have your gear for work separate from your gear from home. So I would have a face shield that you put on at school. I would have a mask that you put on at school. You could even consider having clothes that you wear at school. And so to be on the very conservative side, when you leave school, you could change your mask, you could change your face shield, wash your hands, change your clothes. And then if you want to be like very conservative, when you walk in your house, go into the shower, soak down, and then resume your life. And is that an absolute must? Absolutely not. This is all about risk mitigation. My personal practice is I change out of my hospital clothes when I get home. If I've encountered anybody with infectious symptoms, I take a shower before I do anything else. And that's how I personally choose to practice. But I think those are steps that you can take to keep the folks that you're living with and your loved ones extra safe. So on that note, we'll wrap up. I hope this was helpful for folks. I know these are incredibly confusing times, and there's information coming in all directions. And we're really living in unprecedented times. I hope this has given you a framework in which to think about how you might help yourself and help your students and families be safer as we enter this era. I will continue to post my resources on the tiny URL. I believe we've recorded this webinar, and so we'll post it if you'd like to share it with others. And I wish everybody best of luck in the upcoming school year, whatever that school year might look like for you. Take care.